today's webinar, we have Dr. Heather Jarrell from the New Mexico Office of the Medical Investigator presenting PMCT of blunt force injury. Without further delay, here's Dr. Jarrell.
Well, good day to everyone, and thank you for your participation in today's webinar. My name is Heather Jarrell, and I'm the Chief Medical Investigator at the Office of the Medical Investigator in Albuquerque, New Mexico. And this webinar is on post-mortem CT of blunt force injury. I have nothing to disclose regarding this webinar, and it is targeted, however, to forensic pathologists who are getting started with CT in their practice. So at the OMI, we use postmortem CT practically in some cases to supplant autopsy and in some cases to supplement autopsy. There was a study that was performed by OMI faculty that involved over 1,000 decedents, in which about 3,700 injuries were detected, with a little less than half of those detectable by CT only, and a little less than 1/3 by autopsy only. The cause of death was identical in 85% of cases. And so what we concluded, or what they concluded from this study, is that both autopsy and CT are imperfect, but that they complement each other very well. Additionally, the conclusion was also that postmortem CT may supplant autopsy in selected traumatic fatalities. And that's just what we do at the OMI. We can supplant autopsy in most of the motor vehicle collisions where, and the purpose being that traumatic injury is identified as fatal in the majority of these cases by CT examination and external examination. We can also supplant autopsy in accidental and suicidal falls when there's nothing suspicious and where CT shows lethal trauma. We also use CT and external examination in pedestrian versus motor vehicle collisions. Again, when there's nothing suspicious and nothing that indicates that the pedestrian was run over on purpose. We can, and I'll come back to the pedestrian in the subsequent slides. We also find that CT is extremely useful in homicidal blunt force trauma. And then again, we use CT to supplement autopsy in cases where, such as motor vehicle collisions, where CT does not show lethal trauma. So we'll start by discussing blunt head trauma. This is a 37-year-old man found deceased in his secure residence by reports. He had been working on a 14 feet high unsafe scaffolding. A scene investigation showed that the decedent was found deceased laying on the floor in the hallway of his residence. However, blood was also present throughout the residence, and so the situation was potentially suspicious. We also did an autopsy on this person, but was able to perform a CT prior to autopsy. As you can see, and indicated by the arrow, there is a bulging on the left parietal region. And before I begin to scroll, that is clearly evident. Scrolling through the image, the other aspect that's clearly evident is a right subdural hematoma. Now of note, and stopping here to demonstrate that this bulge on the left parietal region is starting to layer, and you can note that there's two different densities on imaging. This is indicative of hemorrhage, and I'll show you the autopsy correlate in a moment. Another finding that's clearly evident is compression of the right lateral ventricle, and not so much of the left lateral ventricle. And there's a bit of midline shift. In this case, it would be to the left due to the space-occupying hematoma. Scrolling down more distally, you can also see there's some subarachnoid hemorrhage that's evident within the leptomeninges of the gyri. And scrolling even more distally, there is an intraparenchymal hemorrhage of the inferior right temporal lobe. And if you're not careful, you might miss there is a hemorrhage in the brainstem. And so to help sort out these findings and what they mean, we performed an autopsy. Before I go to that, I did want to draw your attention to the view. The first view was the soft tissue window view, and the other one is the bone view to look for any skeletal fractures, which were not evident by this view. The autopsy correlation demonstrated the left parietal subscalpular hematoma, as well as the left subdural hematoma as well. The intraparenchymal hemorrhage, also known as a Duret hemorrhage in this setting, was also present in the pons, which correlated with uncle herniation, and then again we were able to confirm anatomically the presence of a contusion and verify that this is in fact a contusion and is not due to something natural such as an AVM, an arteriovenous malformation. And so it appears the decedent probably fell from the scaffolding. He also has some tonsillar herniation with a contusion as well on the cerebellum. He probably fell from the scaffolding, sustained his blunt head trauma, and had a bleed. Furthermore, what we were also able to demonstrate when stripping the dura from the inside of the basilar skull was that there was a linear, non-depressed skull fracture of the anterior cranial fossa. Now, this was not evident, or at least I could not see it as evident on the post-mortem CT. The 3D rendering and the reconstruction was not obvious to me. And so that is one situation where autopsy proves to be a little more helpful, at least when you're evaluating CT as a forensic pathologist. Okay, now this is a decedent who was a 79-year-old man who was driving the wrong way down the interstate. He collided head-on with another vehicle. And scrolling through the CT as we would normally do, I always start with either the bone or the soft tissue window, and then always go back and look at the brain window as well. What is obvious when you begin scrolling through the head is that there's pneumocephalus. And a person who's not decomposed, then you should be on alert that there's a skull fracture somewhere. If you scroll down, there's really no skull fracture that's obvious until you get down to the basilar skull. And if you look at the basilar skull, there is indeed a basilar skull fracture on the right base of the skull. And you should also expect to see some blood coming out of the ear on external examination as well. Noting on the right half of the screen and scrolling downward, trying to figure out why a 79-year-old man's driving the wrong way down the interstate, one thing to note is that the ventricles are enlarged, and you can kind of make out some faint atrophy of his frontal lobes, and it's probably consistent with neurodegenerative disease, especially in the setting of Alzheimer's disease. So this may be a reason why he was traveling down the wrong side of the road. And so the next slide demonstrates an epidural hematoma, which of course is a hemorrhage in a different compartment, relatively speaking. The history is a 16-year-old female who was found down in the bottom of a cement arroyo. And we did perform an autopsy on her as well, because the circumstances surrounding her death were largely unanswered at the date of autopsy. A radiology showed a convex blood collection in the posterior fossa. A fracture was not clearly visible by CT and was actually in a location that was questionable for a potential suture line versus a fracture. And we did 3D rendering and it didn't demonstrate a fracture. But we did the autopsy and we were able to determine that there was a fracture at the posterior fossa on the left, which is blown up in the photograph below. This is a bit of an unusual location to see an epidural hematoma, but they do happen. Given this location, this represents a fracture, a skull fracture that lacerated the meningeal branch from the occipital artery. So they do happen, and it was associated with death in her case. It's not a great place to have an epidural hematoma in the posterior fossa. Now, CT can also be valuable, of course, for differentiating between blunt trauma and natural disease. This was a 62-year-old woman who was found deceased in her residence. Her history was consistent for falls, and she did, in fact, have multiple bruises on her legs, as well as a bruise on the right posterior scalp. And you can see the arrows showing to a little bulge there. The hemorrhage isn't always very obvious on CT. CT did show a right subdural hemorrhage with right ventricle compression. You can make out the left ventricle and not the ventricle on the contralateral side. There was also, if you are trying to locate another hemorrhage, there is another hemorrhage on the intraparenchymal side, is on the left, what corresponds with the basal ganglia area. And then scrolling more distally, which this is just a photograph that was taken more distally, you can also see some hemorrhage in the brainstem area. So the questions that you have to ask yourself are, is the subdural hemorrhage due to blunt trauma? Is the left intraparenchymal hemorrhage due to hypertensive hemorrhage, or is this something else? And then lastly, does the intraparenchymal hemorrhage in the brainstem represent hypertensive hemorrhage, or is it Durée hemorrhage? And so we felt that doing an autopsy was the best way to help sort out those details. And autopsy demonstrated a right subdural hematoma. You can note the sequelae of that by the gross picture on the right, which shows some cerebral flattening with subsequent mass effect where there is right subfalcine herniation. Of note, there is also a left intraparenchymal hemorrhage that appears to be rising in the left basal ganglia, which is consistent with a hypertensive hemorrhage. And there is no uncal herniation appreciated. And so the last question to answer is the intraparenchymal hemorrhage within the pons due to hypertension, or is this due to sequelae of mass effect from the subdural hematoma? In the absence of uncal herniation, we felt that this likely represented a second intraparenchymal hemorrhage that was due to hypertension. And so microscopically, the intraparenchymal hemorrhage or the hypertensive hemorrhage in the left basal ganglia showed some fibrin and some polymorphonuclear cells and demonstrated some organization within that hemorrhage. The microscopic evaluation of the pontine hemorrhage was identical to the basal ganglia, not to mention that there was also extensive hypertensive vasculopathic changes throughout the brain, and which also supports a hypertensive hemorrhage in etiology. So we felt that she had the hypertensive hemorrhage first, became unconscious, fell and hit her head, and then succumbed to both the blunt head trauma and the natural disease intraparenchymal hemorrhage due to hypertension. Moving on to blunt neck trauma, CT scans throughout some of the literature have been estimated to have anywhere, usually in the lower 70s for sensitivity. So anywhere from about 70% up to 74% sensitivity for detecting cervical spine injuries, with specificities and accuracy upwards in the close to 90% for the detection of fractures. More specifically, the atlas and axis fractures were best visualized with imaging compared to autopsy with the study listed below. And craniocervical fracture dislocations were best identified with autopsy. Now, it is worth noting that when you're trying to evaluate cervical spine fractures, there are search patterns which you should become familiar with. Obviously noting that certain views are going to give you the best view of that area of the spine, and you're more likely to see a fracture with that view. So when you're evaluating posterior elements of the spine, for example, the axial view would be superior. It's my understanding that paraspinous soft tissue injury can be rather difficult to identify on CT examination. And so autopsy may be preferable for that if you're going to look there. For the sagittal view, obviously compression and distraction fractures, anterior dislocation fractures will be preferable on a sagittal view. And then the coronal view specifically will be best for compression fractures or subtle compression fractures as well, and for transverse process fractures. I would also urge you to be cautious in decomposition changes because gas also accumulates within bone. It can cause artifacts that resemble fractures. So just make sure that if you're going to call it a fracture and the person's decomposing, that you're sure about that. Now, sometimes just looking at the skull and the spine, it's obvious that it's not quite right. However, if you need to take a measurement, there are measurements that can help you decide whether there's craniocervical dissociation. One of those is the Bayesian axial interval. And so this is done by just right-clicking and using the measurement annotation. You'll want to draw the line that goes with the curvature of the spine. And so in this case, you want to follow the C2 out to a point. And then you'll take a second measurement from the Bayesian to that line. If that distance is greater than 12 millimeters, then it's consistent with a craniocervical dissociation. So this one, even though it's obvious just by looking at it without taking any measurements, if you need that confirmation with a measurement, that is a measurement that can be used. There's a second measurement called a Bayesian Dens interval. And again, this is pretty obvious that there's been some dissociation. But you'll want to measure the distance between the Bayesian and the tip of the Dens. I extended it out a bit just to make it line up a bit better. If it's greater than 10 millimeters, then that also demonstrates craniocervical dissociation. In this case, we have a measurement at 14 millimeters. And so even though it's obvious, we can confirm with measurements. Okay, so the next case is a evaluation of the odontoid. This was a driver of a motor vehicle who crossed the center line on the highway, struck a vehicle head on and overturned. And so scrolling through the video, you can note this subtle fracture of the odontoid. This represents hyperextension, hyperflexion injuries. And if you remember back from medical school, odontoid fractures can be classified into 3 types. Odontoid fractures are also the most common fracture at C2. Type 1 involves the tip, and it is rare, but it's usually stable. Type 2 involves the base. It's most common in the elderly and in patients with osteoporosis. And then type 3 involves the body. It usually requires a CT for diagnosis, and if the person were to survive, this may need internal fixation. Now, again, this is one where I can't emphasize enough that to look at all the views that are available to you when you're evaluating the cervical spine. And in motor vehicle collisions especially, you want to look at all 3 views, the coronal, the axial, and the sagittal view. And on the sagittal view, it's evident that there is an odontoid fracture, this one being at the base. The next type of fracture is called a Jefferson fracture, which is also a burst kind of fracture. Most cervical spinal cord injuries are the results of axial loading, which is a force directed through the top of the head and down through the spine. It forces the head into a hyperflexion and or rotation. And this can result in a fracture or dislocation of one or more of the cervical vertebrae. So this represents a C1 burst fracture. This may also be or coincide with a vertebral artery injury, which you're not likely to pick up on CT unless you've got some contrast handy. The next slide represents a hangman's fracture, which did indeed get its name from judicial hanging executions where the hanging would occur such that this type of fracture would occur. This happens and is described by a bilateral fracture in the pars interarticularis of the axis. It's often seen with people who are trying to hang themselves, again, mostly in judicial executions, and not so often in common hangings where people commit suicide. But it does also occur in sports accidents and in traffic accidents and in falls. And this fracture is in most cases is lethal. And so if you see it, you can be confident that that is in fact the cause of death. Again, there may be an associated vertebral artery injury. Now, hyperflexion injuries can exist in a wide spectrum. I usually, as a forensic pathologist, just try to identify where the fractures are, and I spend less time trying to classify what they are, as I feel that that's getting outside my area of expertise. And so again, I can't emphasize enough looking at all three views. In the middle view, it's easily appreciable that there's spinal cord injury. There's just no way that there isn't a spinal cord injury associated with this. In scenes where you want to particularly pay attention to the spine, again, as in motor vehicle collisions and a person who's been swimming and diving into shallow water and in high energy type falls. And there may not be multiple, there may just be one. And again, it's nice to document it when you see it, but it's not the cause of death. But this is just a clear example of a vertebral body fracture involving L4. Now, documenting solid organ injury is a little more difficult, and I usually do that when I'm certain. If it's questionable in my mind, then and is not the cause of death, then I usually refrain from documenting it unless I have confirmation from a radiologist. This is a case of a driver who was in a motor vehicle collision and was being pursued by a woman whose purse he stole. He was pronounced deceased on scene. What's evident in the right lung is the Swiss cheese appearance that's called a pneumatocele. And it's when you see that, along with other types of lung lacerations, you can immediately begin to look for a rib fracture. It's not always there, and it wasn't present in this case. But of note, you can also see this type of ground glass appearance adjacent to the laceration, and that's consistent with a pulmonary contusion as well. Now here's another example of a lung laceration where you've got some air into the lung, and then again this ground glass opacity surrounding that is consistent with a contusion. I will admit that sometimes it's a little difficult to differentiate between liver and contusion. Knowing the position of the body and again the circumstances surrounding death can help you sort that out. And in this case, this is more likely to be associated with contusion, given that you've got an adjacent laceration. Now, pneumothoraces are pretty easily recognized on CT, which isn't true with radiographs. Some literature states that upwards to 80% is missed on radiograph because the patient's laying supine and the air accumulates anteriorly. On CT, it's pretty obvious that there's a pneumothorax. on the left here. Also noted, which isn't the right window to look at hemothoraces, but there are bilateral hemothoraces and some lung contusions as well. So pneumothoraces are best seen on the lung window. And then obviously you can see some rib fractures and some subcutaneous emphysema as well. Now, hemothoraces represent injuries to the chest wall, to the intercostal blood vessels, sometimes to the internal mammary arteries, obviously to the great vessels. And when you see hemothoraces of this magnitude, obviously you want to think about an aortic injury, but I almost never find the injury to the specific injury to the aorta, and that's okay. And if you're comfortable explaining in court that this represents massive blunt chest trauma, I've never had an issue with that in court. Now, hemothoraces in textbooks and in real life, they demonstrate layering. And that's evident here, where you can see this, this difference in the density and this actual layer. You can actually see some of that on the other side as well. If you're unsure, then I would recommend doing a needle aspiration on external examination as well. I've had a few cases that looked like layering without any history of trauma and showed some serosanguinous fluid upon needle aspiration. And rib fractures obviously go along with blunt chest trauma. Now, as a forensic pathologist at this office, I don't typically count which ones they are. I look for them and I classify them into their position. So multiple anterolateral rib fractures, multiple bilateral posterior rib fractures, and so on. I find that counting which number, rib number 1, rib number 2, gets confusing, and I'm probably likely to make an error. So I would rather rely on a more general description. I do identify cases that have flailed chest, which is defined as 2 or more contiguous rib fractures with 2 or more breaks per rib, because that obviously can be lethal. Also note that chest tubes can sometimes look just like ribs, but of course you're going to have this marker that's placed on the chest tube that you can see on imaging. Again, noting that there's pneumothorax and subcutaneous emphysema. And so this would be identified as lethal trauma in our office. Now, you also want to make note if CPR was performed, because you would expect some of those anterolateral rib fractures to be from CPR. Another injury that we don't often think about and you could possibly miss if you're not paying attention on axial views is a traumatic diaphragmatic rupture. This is most obvious on the coronal view. It's indicative of severe blunt trauma, and it usually coincides with severe injuries of the thorax. It's most commonly seen on the left side simply because the liver is on the right side. And so if you're scrolling through an axial view and you start to see some intestines immediately adjacent to lung, then immediately go to your coronal view and should be obvious. It's not common. We see it about 1% of the time. Now going back to solid organ injury and moving on to the to the liver, I very seldom am confident calling liver lacerations on postmortem CT. The times where I will allow it is when I see fluid adjacent to the liver that I'm sure is blood. And if you want to look on different views, then that's also helpful to see that this is brighter in these areas. If you're still having trouble, you can use Hounsfield units to help you try to see what that fluid is. The Hounsfield units are a quantitative scale for measuring radiodensity. And for us, it's just a simple right click, use measurements, and I use a region of interest, and I freehand this region, and it calculates a Hounsfield unit for me. Where it's helpful is that uncoagulated blood usually falls between 30 to 45, and clotted blood goes from 60 to 100. And so you can see in this area we have a household unit of 64. And so that's consistent with clotted blood as opposed to something like ascites or some other kind of fluid. Ascites has a much lower Hounsfield unit at 0 to 20. And so that can also be helpful for you as well. Again, here's another example where you can just make out that there is a line here that's indicative of fluid. If you want to know what that fluid is, then you do a Hounsfield unit, and it's 58. And so it's blood, it's probably liquid blood that's accumulated around the liver. Yeah, not uncommonly, you can see some air within there. If you see some air tracking along in a linear pattern and there's no decomposition or air anywhere else, then that might be a laceration. But I'm usually a little more cautious. The same thing with the spleen. Again, it can be very difficult. This is the same patient, and please ignore the projectile as I just pulled this for an example of a spleen bleed. But this shows a nice contour of the spleen, and scrolling distally and changing that window, you can see that there's some fluid here. The Hounsfield unit is 43, which is indicative of some fluid around the spleen, which did show a splenic laceration on autopsy. By the way, the spleen is the most frequently injured solid organ in abdominal injuries. But again, I don't call splenic lacerations very often because I don't see them very often. One thing that might hone you in that there's a spleen laceration is a subjacent rib fracture. It's not uncommon to have, of course, a spleen laceration. With respect to the liver, that's not always true. So you don't necessarily need to see a rib fracture to have a liver laceration. Here's one more example of spleen where you get this wedge-shaped area of hemorrhage here. Lacerations, again, can in the spleen can also appear as linear or branching. I don't find that I'm very comfortable with that interpretation. You can also have some developmental splenic clefts that get mistaken for laceration, and so I usually just back off unless I'm absolutely sure. Well, I hesitated showing this slide, but it's just one of those cases where science just happened to work out. And this was a pedestrian who was struck by a motor vehicle. And on 3D volume reconstruction using CT, there was this wedge-shaped part of a fracture. If you rotate that back to where it is, what it tells you is that the apex of the wedge points in the direction opposite to the direction of the travel of the car. Now, I would never be this bold without already knowing what direction it was. I actually didn't know this until later we found that there was either a witness or a video. And so it happened that the direction of the car coincided with the direction that we would speculate. I tend not to back myself into those kind of corners because the longer you practice, the more you realize sometimes that the reality in textbooks is not the reality as we know it. We do, however, at the OMI, when we have lethal trauma and pedestrian versus motor vehicle collisions, when we have lethal trauma in those cases, we will do an external examination with CT, and we will also do a posterior leg dissection to look for avulsion pockets. And that sometimes is helpful to know whether the person was, or have an idea if the person might have been standing when they were struck by a motor vehicle or were laying down in the roadway. Now, in your evaluation of CT, don't forget the bones that we often don't think about in autopsy, that being a scapula. You can often find scapula fractures. Don't forget the sternum. This is a costochondral dislocation. And don't forget the clavicles as well. I have been told that sternal fractures from resuscitation are most common in the lower portion of the sternum. and sternal fractures in motor vehicle collisions are typically transverse, and they're usually at the third intercostal space. And then don't forget to check the scout films. When I review CTs, I always start with the scout films, and it gives you this nice bird's eye view before you get down into the weeds. It also can be a good reminder to go all the way down to the toes, because there's some pretty significant extremity fractures as well. And especially in elderly patients, you want to look for hip fractures and to see if maybe they broke their hip and that's why they were found down at home. Now, shifting gears a little bit, CT use in children can be helpful. Where I find it to be the most useful is in the evaluation or ruling in blunt trauma or ruling out blunt trauma of the brain and the abdominal and chest cavities. Where I find it to not be particularly helpful for me is evaluation of fractures. As you can see, this is just a normal pediatric CT where you don't see any subdural hemorrhage, but you don't, at least I can't really make out the cortex of the bones. And so if there is a subtle fracture, I'm going to miss that. And so if there is anything suspicious by scene investigation or a bleed within the head, then we will do a full body radiologic survey. And that, I think, is more helpful for evaluating acute and chronic fractures. Again, ruling out blunt trauma is helpful on CT in children. This is a 3-month-old child who on CT has fluid within the abdomen. You can also note that there's air within the peritoneal cavity. That in itself makes you worry about a perforated viscus, which could still be blunt trauma. And when you start looking at this fluid, I can't see that it's layering, but you know, their pediatric CTs, I feel, again, are hard to read. If you do a Hounsfield unit measurement, then it doesn't show to be blood. It in fact was not blood. It was a perforated small intestine, and toxicology was positive for illicit substance, and the child was septic. Now, ruling in trauma is helpful in pediatric cases. You can see on the left that there is a small subdural hematoma on the left parietal region. And there's also this bulge on the right parietal region that turned out to be a hematoma. Scrolling through the bone window, you can see there's a fracture, and these are sutures. If it isn't always evident that they're sutures, but if you look at the other side, it's usually comparable. But this is indeed a fracture in that area. Looking at the lateral view of the skull confirms the presence of a fracture. And I also want to make note that CT can't be used to evaluate for axonal injury, but neither can you reliably use structural MRI to do so, unless the hemorrhage is significant along the long white matter tracts. And that's indicative of a vascular injury, which often coincides with axonal injury. But CT does not evaluate. It's not a tool for evaluation of that. Autopsy correlation does indeed demonstrate a large temporoparietal hematoma and a skull fracture that was pretty significant. And so in summary, my advice would be to know your own limitations in interpreting CT, to know when you need help, and to know when to ask a radiologist for help, and to know the limitations of CT as well. And again, as I've tried to demonstrate, in some cases, such as motor vehicle collisions, CT may completely supplant autopsy. That's especially helpful and valuable in situations where we have a cultural and/or religious objection to an autopsy, and we're able to identify lethal injury, and we're able to honor the family's request to not perform an autopsy. In most cases, we have a CT that complements our autopsy findings, Where I find it to be particularly helpful is that it prepares me for what I need to do heading into autopsy. There's not very many surprises that we're going to encounter in autopsy when you have a CT and you know how to triage those cases. For example, with the pediatric patient, if there's intracranial hemorrhage, I know heading in there that I'm going to be working this case up as a potentially suspicious case. And so with that, I thank you for your attention.
Thank you, Dr. Jarrell, for such a fantastic and informative presentation. Let's go ahead and get right into some questions from the audience. First one I have here are, what types of injuries do you not consider to be lethal, and how could you triage those cases?
So that's a good question. And I will give you examples if we have, for say, a motor vehicle collision and we see only extremity trauma, or we see just a couple of rib fractures, then we will go ahead and do an autopsy on that person. It is entirely possible to have significant and lethal blood loss from femoral fractures. I did have a case several years ago where a person was pinned at the thighs under the dashboard and was convulsive for a period of time, and then died on the way to the hospital after a prolonged extrication procedure. I elected to do an autopsy, and I did make an incision into the thigh, and I verified that there was vessel damage and significant intramuscular hematoma from that femoral fracture. You can see the hemorrhage in the extremity on CT, but I feel that in cases where there's any question in your mind, then obviously CT and autopsy would be the gold standard and give you the most information to be able to evaluate cause and manner of death.
Another question I have here, can CT be used for vertebral, sorry if I butchered that, artery injury?
So CT can show, of course, if say, for example, if you had an aneurysm, you could see the blood collection in the basilar aspect of the skull. When you're evaluating specifically for vertebral artery dissection or injury, otherwise you can use contrast, and it gets to be a bit tricky, but you can actually tie off the subclavians and inject directly into the vertebral artery and then take another image. And the contrast is actually helpful. If you have a hospital that has some expired contrast that they could donate, you can have that on hand. We've used that occasionally here at the OMI to have a nice contrast CT. But if that's not available, then I would do an autopsy.
Gotcha. I got another question here, actually. Are there any unique considerations besides the obvious when reviewing like complex or multi-injury trauma cases? The obvious, I'm assuming, being like the fact that there are multiple injuries probably makes it harder to review the scan. Is there anything in addition to that is a unique consideration to keep in mind?
I'm sorry, can you ask that one more time?
Sure. Are there any unique considerations when reviewing like a case that has like a complex multi-traumatic injury situation? Anything beyond the obvious of, again, like I'm assuming what they're saying is like, obviously a multi-injury has several places, several different parts of the body that needs to be reviewed, but is there anything beyond just the obvious to keep in mind or have under consideration while reviewing those type of cases?
I think I understand what you're asking. I would say that as long as you can tie it all together to one single, say, blunt trauma and a motor vehicle collision or from a fall. But if there's one injury that stands out or one finding that stands out that could have a natural component. Say there's a healing rib fracture and you have an adjacent pneumonia. That would probably be a case that I would autopsy because there's pneumonia there, and I'd want to see do cultures on the pneumonia. And so every case is different, and so that's what makes practicing with CT a bit of a learning curve. There's definitely cases or decedents who I've done an autopsy with that I probably could have just done a CT and an external, and there's also the flip side of that is true too. And you continue to get more comfortable the longer you utilize CT, but there's definitely situations where I can't explain all the findings, and so at that point I would prefer to do a full autopsy.
Sure. So again, harping on the same line that everyone who's joined us this far in the series, using CT is definitely a valuable tool, valuable asset to pair with the more standard procedures for medical investigation. Another question I have here from the audience: if you did a CT only exam, no autopsy, after a motor vehicle event to honor a religious objection, and the CT does not show clearly fatal injury, what would you do in that situation?
So that's also a good question. I would call and have the conversation that CT doesn't show fatal injury, and I would urge an autopsy at that point. If the religious consideration is so strong, and if it's our case, say it's not our jurisdiction but we're being consulted, then I would honor whatever the consulting party wants to do. If it is our jurisdiction, I would call the family and let them know that we don't have lethal trauma, and this would be an instance where I would do an autopsy. In the case where if it's not our jurisdiction, we're being consulted and I don't see lethal trauma, I would let them know that I could certify this as undetermined at this point. It's possible that the person had, a myocardial infarction and then crash, and it depends also on the CT findings. Not to contradict myself, we have had some cases where there was significant coronary artery atherosclerosis, and it appeared to be a low speed crash, and we've certified with ASCVD and natural. It just depends on what the findings are and what we're seeing on CT. I hope that answers your question and didn't completely muddy the water.
Well, normally the audience is pretty good at letting us know if they need a follow-up question. So if they do, I'm sure we'll get it here in a second. I have another question here. Do you include a disclaimer in your reports for the limitation of a pathologist interpreting CT findings?
That's a good question. I do. At the beginning of my CT interpretation module, I always say a full body postmortem computed tomography scan was reviewed by the pathologist, and so I make it clear that I'm a pathologist and I'm reviewing, and I'm also very quick to say in court I'm a pathologist, and if there's something subtle, of course a radiologist would find that, and I'm probably going to miss something that's very subtle.
Another question I have here, and I think this ties into, I know there was one case that you had mentioned in the presentation where the person was driving on the wrong side of the road. And then after reviewing the scans and doing the normal process for the MDI, the kind of found that there was some possible signs of Alzheimer's disease in that case. So in that same vein, does the OMI have specific standard operating procedures or process flows that work through identifying / eliminating kind of common comorbidities when reviewing the scans? Just, not to have I guess the best way to describe this is there any way that you have found how to eliminate kind of some of those red herrings that might pop up while you're reviewing the scans?
I don't. So I will say that when I review a CT, I am not only evaluating for injury. So even in a motor vehicle collision, I am naming all of the trauma that I see, but I'm also in every instance identifying all the natural disease that I find. And so, and even if there's fatal blunt chest trauma, I'm still identifying coronary artery atherosclerosis, aortic atherosclerosis, chronic hypertensive changes of the kidneys, and so on. And so we are documenting all of that. It's somewhat searchable through our database. And so and to answer that question, I don't think we've specifically developed an SOP for that, but it's searchable.
Gotcha. Well, I appreciate you working through some of these questions. It seems like we're kind of at the end of our list. I'll go ahead and allow the audience one final chance to send in your questions. And while we're waiting on that, I want to let everybody in the audience know that this is the fourth in a 6-part series on postmortem computed tomography. So we've got the next webinar in the series, which is PMCT of natural disease, and that'll be next Tuesday, May 11th at 1. And we just had the third in the series last week, which was the PMCT of gunshot wounds. So if you need to catch up, we've got those all on the FTCOE website in archival form, and this one as well will be archived and available within the next 2 weeks. And please join us for the next webinar in the series. We'll do one last, oh, here we go. We've got another final question. Can CT assist in differentiating injury from strangulation versus hanging?
I would say the answer to that would be no. Most of the, and 99% of the hanging cases that we see, there's nothing significant on CT. And if there is a concern for strangulation, of course, you may or may not see a hyoid fracture, and CT doesn't always demonstrate a hyoid fracture when they're present. But if strangulation's in the differential, if there's anything suspicious, then we would autopsy those folks. And so I would answer your question with no.
All right. Well, I think that rounds out our questions from the audience. So we'll go ahead and start closing out today's webinar. I want to go ahead and first thank our subject matter expert for taking the time out of their day to present the material for today's webinar. So thank you again, Dr. Jarrell, for taking the time to provide such a fantastic presentation.
Thank you.
And again, as a reminder, this was the fourth webinar in a 6-part series. We've got the next one up, which is PMCT of natural disease. That'll be next Tuesday, May 11th at 1 p.m. Eastern. And we hope you can join us. We would also like to take this time to thank our audience for joining us today. These webinars would not be possible without your attendance and support. Before you leave today's webinar, we would like to ask you to participate in a short survey. You can locate that link back on the webinar's main page. Simply click the word survey, and that will bring up our quick customer satisfaction survey for today's event. Your feedback about our webinars is vital information that we use to provide you with the best webinar experience and adjust the content and the way we disseminate the information to our audience. One more thing to draw your attention to, you should see we are putting links into the chat to all our social media pages, such as Facebook, LinkedIn, and Twitter, as well as a link to our website at forensiccoe.org and a link directly to our podcast episodes. Make sure you are following us on social media and subscribe to our newsletter to stay up to date with everything that FTCOE is doing in the forensic community. Thank you again for attending, and we hope everyone has a great rest of your day.